This presentation is part 2 of drugs affecting the respiratory system. Okay, starting with corticosteroids. The inhaled corticosteroids inhibit immunoglobulin E and mast cell-mediated migration of inflammatory cells occurring in the bronchial tissue. So they can be considered a late phase allergic reactant. So in the allergy response, the IgE-mediated response, allergic response, you have the late phase allergic reaction, and that's where the corticosteroids work. So there's the purpose is, of course, to reduce the severity of asthma, to increase their peak flows, to decrease the airway hyperresponsiveness. And so remember, there are really 3 mechanisms that we have to watch for with patients that have asthma. They have bronchospasm, so narrowing of the airways for that reason. They have the inflammatory response, which causes mucus in the airway, further reducing the lumen of the airway and causing narrowed airways. And then we also have to address the airway hyperresponsiveness that we see in patients that have allergies when they get exposed to allergies, such as pollen or cigarette smoke, whatever it might be. So the exact mechanism of action by which they inhibit the bronchoconstrictor mechanisms and the way they produce smooth muscle relaxation is not really known. So pharmacokinetics for the inhaled corticosteroids. Absorption occurs from the lungs and the GI tract because, of course, it's swallowed. A lot of it is swallowed. 10 to 30% of the dose is delivered to the lungs. And unfortunately, if there's no spacer device used, 80% of this dose can be swallowed. Some of the precautions with inhaled corticosteroids. First of all, I do want to say that, reminder that they're not for relief of acute bronchospasm. And they're also not a substitute for oral corticosteroids. Patients often need both. There is some risk of the HPA axis suppression, but it is low with inhaled corticosteroids. But there is an increased risk if they're being administered with the patient who's already taking oral steroids. We should avoid giving corticosteroids in patients that have Cushing's syndrome, and they should be used with caution in patients that have herpes, especially ocular herpes simplex infections, TB, and for those, the reason for those is because it could cause an exacerbation of both of these conditions because of the immune compromised state. Oral or nasal surgery or trauma, that would be more of an issue, giving topical inhaled corticosteroids. If they have septal ulcers, especially if you're using nasal inhalers, inhaled steroids. And any patient that has an untreated respiratory infection, you don't want to just give them steroids. If there is a risk that they have a fungal or bacterial infection, especially, but even with a viral infection, it could worsen their symptoms, so worsen their infection. So you want to make sure that if there is any underlying bacterial or fungal infection, that we are treating those as well as treating the bronchospasm that may be a complication of those. The inhaled steroids do have some interactions. Fluticasone, the plasma concentration of fluticasone can be increased by ritonavir, an antiviral, and ketoconazole, an antifungal. Also, budesonide can have increased concentration levels with ketoconazole, but other corticosteroids do not have any known drug interactions. The inhaled steroids are indicated for persistent asthma as well as COPD. We're going to talk more about choosing what combinations of drugs can be used in these conditions later. But in persistent asthma of moderate level, We can use a low to medium dose inhaled corticosteroid with a long-acting beta agonist, and examples of this would be Advair or Breo. For severe asthma that's persistent, we'll use high-dose beta agonists as well as steroids. For COPD, they can work as both monotherapy and in combination with inhaled bronchodilators, but more about that later. These are some of the things to think about in terms of monitoring and education for patients using the steroids. If they're on high-dose steroids, they need to have their glucose monitored. If they're diabetic, they need to be aware of this. Generally, we see increases in glucose with oral steroids, but if they're on high-dose steroids for quite a long time that are inhaled, they may also have fluctuations or increases in their glucose. Potassium may also need to be monitored in patients on long-term high-dose use. For everyone using inhaled steroids, they should be using spacer devices. I can't stress enough how much more this enhances the amount of steroid they actually get into their lungs. Using devices that are pumps need to have spacer devices. If you're using something like Advair or Breo that has a built-in system for ease of delivery, you don't need a spacer device. But if anyone that is using a metered dose inhaler or pump, as they're commonly called, you need to have a spacer device. Also, rinsing their mouth with water is very important, whether they're using an intranasal or an inhaled steroid. The intranasal steroids, you also need to be concerned about clearing the nasal passages of mucus. So if they have a lot of rhinorrhea, they're going to need to clear that out before they use their nasal steroid. Some ADRs that we need to think about with the inhaled steroids. Local immunosuppression can occur, so patients can get oral candidiasis. This is why they need to rinse their mouth out with water after using them. Also, if you're using intranasal steroids, there can be nasal irritation, bleeding, dryness, even perforation. Some of the other concerns that we might see, xerostomia, hoarseness, tongue irritation, dyspepsia, altered taste sensation can also occur. Some of the less common but more severe ADRs are listed here. We know with long-term use, we need to be aware of cataracts. Actually, some people will have a paradoxical increase in bronchospasm or even laryngospasm. If we're using oral steroids in conjunction with inhaled steroids, there's more of a possibility of HPA suppression, as I mentioned previously. We can also see pulmonary infiltrates with the eosinophilia, hyperglycemia and hypokalemia already mentioned. Glucose and potassium need to be monitored. With long-term use, we will also need to monitor for osteoporosis. And some patients will have hypertension or hypotension. And now we move on to the inhaled anticholinergics. Atrovent blocks muscarinic cholinergic receptors. Spiriva and Tudorza-Pressair inhibit the muscarinic M3 receptors in the lungs. All of these anticholinergics can cause bronchial smooth muscle relaxation. These are used more in the treatment of COPD than in asthma, but they may be used in acute exacerbations when the patient cannot tolerate beta agonists, so we can keep that in mind. So blocking the cholinergic receptors decreases the formation of a substance called cyclic guanosine monophosphate, or cyclic GNP, and that leads to a decreased contractility of the smooth muscles of the lungs, probably because of the actions of cyclic GNP on intracellular calcium. Generally, the anticholinergics are poorly absorbed systemically from the lungs and the GI tract, and this is why it's really important to use spacer devices for these drugs as well. Apparently 90% of ipratropium is swallowed and excreted in the feces unchanged. Indications for these anticholinergics. For COPD, we can use ipratropium bromide. We can also use a combination ipratropium albuterol, which is Combivent, Tiotropium is Spiriva, and that's also indicated in COPD. And then, as I mentioned before, Tadura Pressair is another example of an anticholinergic we can use for COPD. For asthma, we can use Atrovent, and that's generally given for maintenance 2 to 3 plus 4 times a day for adults. We can also use this in children, generally through a nebulizer, and the dosing is dependent on age. Ipratropium bromide and albuterol combination is Combivent, so Atrovent and albuterol. And that can also be used as second-line rescue inhaler in the treatment of asthma. Spiriva may be used for the maintenance of asthma, but there's no indication for Pressair to be used for asthma. That is only used for COPD. Some precautions with the inhaled anticholinergics. Of course, if there's a known hypersensitivity, we're not going to use them. They are not used for acute bronchospasm unless they're combined with a beta agonist. As I mentioned, Combivent is something that can be used as a rescue inhaler. Ipratropium bromide is safe in pregnancy, but Spiriva is used with caution in pregnancy. Cough is the most common side effect with the anticholinergics. Dry mouth, also common. And other anticholinergic effects that we see in any anticholinergic include constipation and urinary retention, but those are generally not very common. And then rarely there's an allergic reaction. Allergy to soybeans, legumes, or soy lecithin appears to be correlated with a hypersensitivity to ipratropium bromide. Next category is inhaled anti-inflammatories, actually cromolyn. Cromolyn inhibits antigen-induced bronchospasm. It's a mast cell stabilizer, so it blocks the release of histamine and slow-reacting substance of anaphylaxis, which is also called SRSA. It can prevent the release of leukotrienes, but is not a bronchodilator, so it's contraindicated in acute bronchospasm. Cromolyn can be used for exercise-induced asthma or as another maintenance drug for asthma. Now I'm going to talk about the approach to treatment of asthma and COPD. So let's just talk about asthma step therapy. As I mentioned earlier, there's an expert panel 4, which is in the works, but this is, and these expert panels come from the National Asthma Education and Prevention Panel. And so these are based off of the 2007 expert panel 3 recommendations. So first you need to determine the severity of symptoms, and then you go to a step therapy chart and start at the recommended step based on where the patient is. And what you want is an aggressive approach. You don't hold off on, for example, giving steroids because you can have an acute exacerbation that goes sour pretty quickly. So you want to prevent asthma exacerbations. That's the goal of therapy. You want to keep patients out of the hospital. You want to prevent them from needing to use, have frequent use of a rescue inhaler. So asthma control can be defined as the degree to which manifestations of asthma are minimized by therapeutic interventions and the goals of therapy are met. Asthma is classified according to its degree of severity, and we use a stepwise approach to treatment of asthma based on its degree of severity. Mild intermittent asthma is when people have symptoms less than 2 days per week. Mild persistent, symptoms greater than 2 days a week, but not daily. Moderate persistent is when they have symptoms on a daily basis, and severe is when they have symptoms throughout the day. So in step 1 therapy is where we are with mild intermittent asthma. So patients have symptoms when they're exposed to triggers. That's called mild intermittent asthma. So you might have a patient who only has an asthma attack during the pollen season, or when they come in contact with smoke, or when they come in contact with pets. And in these patients, you just use a short-acting beta-2 agonist. In mild persistent asthma, they are needing to use their beta agonists 2 days or more per week. If that's the case, then they have to step up therapy. Another exacerbation that's common is upper respiratory viral infections. So those patients, if they start needing to use their rescue inhaler more frequently, then you need to step up their therapy. And so you treat them with long-term control medication, such as a low-dose inhaled corticosteroid, cromolyn, or whatever. You need to consult the dosage charts to see how to go from low dose to more potent drugs. In moderate persistent asthma, we go to step 3 therapy. And so these patients have, they have persistent symptoms of asthma. They need low-dose inhaled steroids plus a long-acting beta agonist. They can also use medium-dose inhaled steroid with a leukotriene receptor modifier. They may use short-acting beta agonists, and they may have exacerbations that require oral corticosteroids. In patients that have severe persistent asthma, we have step 4, step 5, step 6 therapy. And when you get to that level of intervention needed, especially at steps 5 and 6, you may need to consult a specialist. So in managing exacerbations, we can also often treat patients with oral steroids to get control. And you can do short bursts of 40 to 60 milligrams of, say, prednisone a day for 5 to 10 days. I don't use Medrol dose pack for this. I use prednisone at 20 milligrams, and they can be taken all at once. You don't need to do 3-time-a-day thing. You can do 3 pills for 60 milligrams a day, once a day. And there are doses for children, 1 to 2 milligrams per kilogram per day. And if not effective, then you need to step up the therapy with other agents. As far as COPD is concerned, there's also staging for that as well, and that's based on post-bronchodilator ratio of less than 0.7. That makes the diagnosis of COPD when there is no reversibility or limited reversibility of bronchospasm. And staging is according to the FEV1% predicted, as you can see here, mild, moderate, severe, and very severe. And there are a variety of therapies for COPD, as you can see here, some of which are non-pharmacologic. In terms of bronchodilators, we have the beta agonists, the short-acting and the long-acting. The methylxanthines, like theophylline, has some benefit in COPD. Corticosteroids have limited use in COPD as far as inhaled. Oral steroids can be used for exacerbations. Long-term use of low-dose oral steroids have limited effect, but are used when patients have really severe COPD. Anticholinergics, the anti-muscarinic agents like Atrovent and Spiriva can reduce the volume of sputum and cause some bronchodilation. And that's it for this presentation.